It is now my great honor to present our plenary speaker, Dr. Ruth Wilson. Ruth is the person who conceived and directed the bold and far-reaching efforts to reform primary care service delivery in Ontario. She is currently the North American Regional President for WONCA, our World Organization of Family Physicians. Elle a été chef du département de médecine familiale de l'Université Queen's à Kingston, en Ontario, pendant 10 ans. De plus, elle était la présidente du Collège des médecins de famille du Canada. À titre de médecin de famille, elle a pratiqué dans les régions éloignées pendant plusieurs années. She is the recipient of a Canada 125 medal and the Diamond Jubilee Medal. In 2002, Dr. Wilson received an honorary degree of laws. In 2010, she was named one of 2 global 5-star physicians. And also that year, she was named one of Canada's top 100 most powerful women. She was also awarded the Order of Canada in July 2015. Mesdames et messieurs, je vous présente le Dr. Ruth Wilson.
Bonjour tout le monde. Moi aussi, je vous souhaite le bienvenue à Montréal. I feel that I'm amongst friends, and NAPCRG has always been that nurturing, friendly environment. So please join with me as a friend as we go through these perspectives together. I also want to start by acknowledging that we are today on the traditional lands of the Mohawk Nation and people, and this acknowledgement is part of the work of reconciliation that we are called to do as citizens, as physicians, as researchers. Also a great time to celebrate Canada's 150th anniversary, 375 years of the founding of Montreal, and 45 years of NAPCRG. So I'm going to take you through some ideas, perspectives globally and also from Canada and from where I come from in Kingston, Ontario, hoping to challenge you and perhaps give you some inspiration for the important work you do. This map is produced by Polaris, which is the Young Doctors Movement of WONCA, and it shows the words family medicine in many of the languages of the world. Of course, here in Canada, we also have a word map to describe the work we do, and I want to talk a little bit about Canada's healthcare system and my thoughts on it as well as those of others. In Canada, we're very proud of Tommy Douglas, who started our universal free at the point of access, publicly funded healthcare system. For those of you from the US, if you don't know Tommy, you might know his grandson, Kiefer Sutherland. So here's a perspective. 3 out of 4 Canadians think we have the best healthcare system in the world. They're probably wrong, but we like to believe that about ourselves. So we'll be talking a little bit about the values that Canadians hold for their healthcare system, but also some of the challenges that we have. I wanted to acknowledge, though, 2 important contributions Canada has made to medicine and clinical methods. So the first slide shows a man who grew up in Dundas, Ontario, near where McMaster University is, went to school north of Toronto, moved to McGill, where his curiosity impelled him to do over 1,000 autopsies during his time there, then moved to Hopkins, and then on to Oxford, where he became the Regius Professor of Medicine. And by now, of course, you'll know that this is Sir William Osler. So on the slide, where he's illustrating the clinical method that many of us were taught, he's top left inspecting, top right auscultating, bottom left palpating, and bottom right contemplating. We've also made from Canada, and we're very proud of the originators and founders of the patient-centered clinical method. And I understand Moira is going to be giving the Morris Wood oration later in the meeting, and I expect she'll tell you more about this illustrious group. But this patient-centered clinical method now is second nature to all of us who practice. I put up this old, used to be an overhead that I used to use for teaching, just to show how long we've been relying on this way of thinking about the clinical consultation with our patients, the doctor's agenda and the patient's agenda. So two things from Canada that we're very proud of. Our friends from the US are here. Hands up, how many of you are from the US? Wow, the majority, I would say, yeah. We have such a close relationship with the US. From my home in Kingston, I can look down the end of the street and see the US across the river. And we're watching with interest the contributions that are coming from the US. Here's a perspective from Donald Trump. He said this in the campaign prior to his election. Canadians, when they need a big operation, they come to the US in many cases because their system is so slow. And it's a perspective. I'm going to explore some of the truth and some of the facts around it later. I can tell you one thing, nobody knows how many Canadians go to the US for the big operations, so there's a research question for you. I also want to just say we're all engaged in the work of protecting our environment, and there's been some challenges recently to the science of climate change, but I'm pleased to show you that there's some new evidence which has just emerged. So I suppose it's a correlation. All right, so Richard Horton in The Lancet just a couple of years ago had an article which is not very inspiring, but it's about how to save primary care research, and he references a meeting that he was at some years ago. He attended a meeting of WONCA, he says, held in the cold, remote wastelands of Canada. So, of course, when you read this, you think he might have been up in Iqaluit, where my husband, Ian Casson, and I have done a couple of locums. You might think Horton was up in Iqaluit, but no, he was actually in the land of Walt Rosser, my home department, the Department of Family Medicine at Queen's University in Kingston, Ontario. I know many of you know Walt, and he's just this year retired from clinical practice. We are, as I mentioned, located right on the border with the US, and we can be cold, it's true. So that's where I hail from, and I've got a few contributions that our department has made to primary care research coming up in a little bit. All right, let's launch into some global perspectives. So you remember the Millennium Development Goals, which have now been replaced by the Sustainable Development Goals, and Goal 3 is about health, but it of course interacts with all the other important goals that our planet needs to achieve to sustain and promote health. Goal 3 is to ensure healthy lives and promote well-being for all at all ages. So how do we do that? This is a map that you might for a moment contemplate and see if you can figure out what it is about the countries which are in green or blue, what they have in common. Light green will just, that is an outlier, so just ignore that for a moment. And I think most of you will now be aware that the colors either in blue or in dark green are countries that have universal health coverage, funded either by the beverage system in the case of blue, so taxpayer funded, or the Bismarckian system in the case of green, so funded by social insurance and employer-based insurance. Dr. Margaret Chan, the former WHO director, has this powerful statement: I regard universal health coverage as the single most powerful concept that public health has to offer. That's, to me, amazing, because we often think of primary care and public health as being maybe two sides of a coin, or sometimes maybe in opposition. But here she is saying universal health coverage, single most powerful concept that public health has to offer. It's inclusive, it unifies services, delivers them in a comprehensive and integrated way based on primary health care. Margaret Chan attended our Wonka conference, and here she is holding a copy of our guidebook, which if you haven't seen it, is well worth looking at, the contribution of family medicine to strengthening healthcare systems. Lots of great evidence about the work that we do and how we can contribute to equity in health. And she goes on to say that a healthcare system where primary care is the backbone and family doctors are the bedrock delivers the best health outcomes at the lowest cost with the greatest user satisfaction. The triple aim, and of course now we have the quadruple aim where we want to have healthy and happy healthcare providers as well. And she's of course relying on Starfield's evidence in her statement here. So the work we do as family doctors contributes tremendously to the equity and promise of universal health coverage, which contributes to the Sustainable Development Goal 3 of health for all. These features of family medicine in our guidebook are well known to any of you, but they're always worth reminding ourselves of and evaluating anything we do against these principles. How well are we fostering these in our work? And as Starfield reminded us, what is needed is person-focused care over time, not disease-focused care. All right, now equity versus equality, and I think this slide shows the difference very nicely, is something that we're striving for in all of our countries and all of our healthcare systems. And we have known for years, since the Whitehall study in the UK, that health and wealth are in lockstep. So the richer you are, the more likely you are to be healthy. And this is beyond the effects of poverty. So you'll recall the Whitehall study looked at UK civil servants, and it turned out all of them, of course, were employed, but the bus driver had poor health status as compared to the deputy minister. So health and wealth, we know, have been associated in lockstep. But the more recent information, and I expect many of you know this, is that there is a determinant of health which goes beyond health, wealth, poverty, and it is about inequity. So Wilkinson and Pickett have looked at a variety of indicators and show convincingly, to me at least, that health and social problems are worse the greater the inequity in a country. So if you're a rich person in a country where the CEO makes 500 times what the shop floor maker makes, your health is going to be worse than if you're a rich person in a more egalitarian society where the CEO's income is perhaps 5 times that of the worker on the shop floor. So countries like Japan, where there is more equity and egalitarianism in their social system, have better health outcomes, but also outcomes that are surprising, things like obesity, literacy rates, addictions, imprisonment, teenage births, and so on. And of course, we all know about the corrosive effects of inequity, and all of us want to see what we can do to correct that. But I think we often feel frustrated in our work and wonder what on earth we can do about CEO incomes and how we can decrease income inequity in our countries. Well, of course, the great news from Starfield, and this to me is thrilling work, and it's old work, but it still thrills me, is that the work we do every day in primary care, those day-to-day, seemingly small interactions with individuals, can help overcome the corrosive effects of inequity. So not only do we improve healthcare status at low cost and with greater user satisfaction, with better outcomes, we can also make a difference to the effects of inequity in our communities. So work well worth doing. And the days that I get bogged down in paperwork and EMR and all the other frustrations, I try to keep that top of my mind. The relationships we have matter. This is a picture of me at a delivery with 2 actual Queen's students. They are not models. And this woman, I had been my patient since she was 11. She had appendicitis when she went to summer camp one year, and I had always been worried about her fertility. And indeed, she did have trouble conceiving. She went on to try in vitro fertilization, and the day she found out that the embryos were non-viable was the day that she found out she was pregnant on her own, with the help of her husband, of course. She was due December 23rd, and I carried that beeper all that Christmas, 5 years ago now, and finally induced her on January 3rd, so I always remember her daughter's birthday. So why am I telling you this story? Nothing in particular, except it's a happy story for me. But it is an introduction to thinking about causes of mortality and morbidity around the world. And so what is the health status of the world? Are people getting healthier or less healthy? Are we achieving that sustainable development goal or not? And of course, like all news, it's good news and bad news. We have a tremendous reduction in maternal deaths around the world. Look at that, from 532,000 per annum to 303,000. But still, every day, over 800 women die in childbirth. So much work to be done, so much progress being made, but a tremendous call to all of us. And of course, in the US, not of course, sadly in the US, we're seeing a rise in maternal mortality, which is, to me, almost inexplicable, and I hope some of you are thinking about why this is happening. And it's not just amongst the poor. If you'd like to look at a heartrending story of a doctor and his nurse wife where she died in childbirth, ProPublica on its website has a very moving piece on that. So I use maternal deaths because it's an area of interest of mine, but also to illustrate that we can't let down our guard in any of our countries about major causes of morbidity and mortality. But as you know, the whole world now has undergone the epidemiologic transition, so the scourge of infectious diseases is waning, and the rise of chronic diseases or non-communicable diseases is on the increase. My husband and I worked in northwestern Ontario in Sioux Lookout for 6 years, and during the time we were there, I only remember seeing one person with a myocardial infarction, and it was an RCMP officer. But all kinds of deaths, sadly, from tuberculosis. Our first publication described 100 cases of diphtheria, of course, empyema, H. flu disease, a death from measles that I recall. So all of those infectious diseases still present in the 80s in our Indigenous populations in Canada, but then rapidly, very rapidly, the transition to the chronic diseases, diabetes in particular, ischemic heart disease. And of course, some of our communities continue to suffer from both infectious diseases and chronic diseases. For example, in Nunavut, where the incidence of tuberculosis is, well, I just talked to a first-year doctor who's working in Iqaluit, and she told me her last emerged shift, she had 3 cases of tuberculosis, one of which was TB encephalitis. So still a scourge in our communities. And of course, all of this is against the backdrop of the health human resource challenges that we're facing. These are doctor population ratios throughout the world. And although we complain, and I'm going to show you some complaints about wait times and difficulty accessing care, we need to remember that many, many countries in the world are less well off than we are in terms of that, and that there is a projected deficit of millions of healthcare workers in the future. So what's being done? We of course see this recent announcement about the Global Fund donating money for some of the important causes of mortality in our world. We worry, of course, about vertical programs. Vertical programs have their role, but we have a quote from a fellow in Nigeria who says he had diabetes. He said, it would be better if I had HIV/AIDS, because at least there's a clinic that provides HIV/AIDS services, but there's no primary care, there's no place I can go for my diabetes. So I think we're rightly pleased but cautious about vertical programs and their funding. And of course, we now have the launch of the Primary Healthcare Performance Initiatives, a very welcome initiative, and you can see the partners who are there along with WONCA, looking at the ways we can track spending and outcomes for primary healthcare performance. And their website is well worth a look. Strong primary healthcare is the foundation of strong health systems. But I want to show you this picture. This is one my husband took a couple of years ago. He and I were doing a locum in the Northwest Territories in Fort Simpson. And he took the picture because I'm walking along the Mackenzie River. This was our commute to work. Mackenzie River is the longest river in Canada. And on my short walk on that dirt road, I like to think about the fact that Mackenzie and Franklin and many Indigenous peoples, many other explorers would have gone by in canoes right where I was standing. The reason I'm showing this picture in the context, though, of primary health care indicators is to recall something that our Wonka president, Amanda Howe, wrote in this month's Wonka e-News. And Amanda, I don't have your exact words, but I think your idea is this, that it's all very well and important to measure primary health care indicators and outcomes, but it's also a really good idea to just have primary health care. Let's work also on establishing primary care around the world and in Fort Simpson, where Ian and I, for 2 weeks, relieved a doctor who had been single-handed, so on call on his own for the previous month. So again, in our own country and around the world, lots of work to do in establishing primary care. A bit about our Canadian healthcare system. It's, I guess, one of these complex adaptive systems. You can try to make, and you can make significant changes, and Bill kindly referred to the work we did in Ontario. And of course, the unintended consequences and knock-on effects are not always predictable. This is the small corrective to the 3/4 of Canadians who think our healthcare system is the best in the world. You know, this crowd knows the Commonwealth rankings, and of course, great celebration in Canada when this year we moved from 10th to 9th in our overall ranking amongst OECD countries. How do you measure a healthcare system? How do you measure how well we're doing? Life expectancy at birth is one way, and by those measures, perhaps Canada's doing not too badly. But some of these statistics, of course, are worrying to me and to you, and this now is what I guess my reflection on what the 3/4 of Canadians think and what Donald Trump thinks about our system. Compared to other OECD countries, patients say that they, and doctors say that after our access to care is significantly below average. Those of us who are practicing, myself included, happen to think that we provide pretty good access, but our patients don't agree with us. So I told you the story about carrying that beeper over Christmas, but so I think, you know, I'm doing my bit, but our patients either are unaware or we haven't made it easy for them, or in any case, they feel they don't have the access that we believe they do. This was tweeted out by a colleague of mine in Kingston just last week, Dr. Joy Hatley, and she made a referral to a specific neurologist and got this letter back saying that the wait time is between 4 and 5 years, and suggested that she might want to redirect the referral to Toronto or Ottawa. So I've never experienced this myself, but she certainly did. So, and this is one specific motor diseases unit where, you know, there's been some short staffing and so on. But this is an appalling situation. So part of what Donald Trump has to say about our wait times, I'm afraid, is true. And the statistics from the Commonwealth Fund bear this out, that wait times for specialists are the longest in Canada, at least according to those of us in primary care, compared to other OECD countries. We do wait a long time to see specialists, but the good news, and I think one of the reasons Canadians do value our system, is that priority surgeries are handled very expeditiously, and Canadians know that if they have life or limb-threatening conditions, they will, by and large, get timely access to care, and they will be triaged. And it is one of our deeply held values that I also subscribe to, that healthcare in Canada is allocated on the basis of need, not on the basis of how much you can pay. So I'm always puzzled about this debate about, is healthcare a right or a consumer good? Atul Gawande had a nice article in New Yorker recently on this question, and I think in Canada we would not even, most of us would not even question the idea that healthcare is a right rather than something that you can purchase more of if you have the funds to do so. So I think we do well on urgent conditions. access to diagnostic imaging, somewhat of a difficulty in Canada, although I have the ability to directly order MRIs or CTs, which in my experience are triaged appropriately. Coordination with specialists, better than average in Canada, but none of us is doing well in terms of our interactions with other specialists. And of course, we bemoan the demise of the role of the family doctor in the hospital and the way we used to rub shoulders in the doctor's lounge. And we haven't found good ways to improve that, although in Ottawa and Kingston areas, the e-consult project, I think, has been, in my clinical experience, a great way to start to get out of the need to have patients see specialists face-to-face in order to get an opinion, but rather to do it electronically. Coordination with hospitals, same theme, not very good anywhere. Big problem in Canada are medication costs. Medications are covered for patients over 65, those who are on social assistance, and those who have workplace insurance, but there are still those who can't. So, for example, I have a patient who works at Tim Hortons, our iconic, we love our Tims, and he has epilepsy and tells me he can't afford, and I believe him, can't afford to pay for his anti-epileptic medications. So he came in recently having had another seizure at work at night when he's the only baker on duty, saying, I think I should go on disability. At least my drugs would be paid for. So here's a man who's able to work, but not able to afford his medication, which would allow him to continue to safely work. So important priority for our country. And none of us is doing a good job integrating primary care and home care services. As our population, my optometrist said, he didn't call me aging, he said something about, you've had lots of birthdays. So the thing of, as our population starts to have lots of birthdays, we're going to need better integration of primary care and home care services. Danielle Martin, family doctor based in Toronto, has written a great book on 6 ideas she thinks we need to undertake in Canada to improve our healthcare system. These will resonate very well with you and a bit with what I've said. The return to relationships, so that each person has a relationship-based healthcare system. Drug coverage I've mentioned, and then the need to reduce unnecessary tests and interventions. I had a brief conversation on the train last night with Dale McMurtry about the Choosing Wisely program in Canada and the importance of stewardship of our healthcare system and how we as providers have a role to play in reducing unnecessary tests. Being more efficient in our healthcare system, I am part of a health policy group at Queen's that includes Don Drummond, former deputy minister or deputy governor of the Bank of Canada and TD economist. His analysis suggests that healthcare costs are going to grow on the basis of population growth, the aging population, and technology at about 6% a year, and GDP is going to grow at about 2 to 3% a year. And he's convinced that the only way we'll sustain our healthcare system is with doing better with not quite as much as we'd like. So innovations and efficiencies are important. Dr. Martin suggests a basic income, guaranteed annual income, which has bipartisan support in our country, something I support myself. And then scaling up. We're a nation of pilot projects, and so scaling and spreading change, first, 6th big idea. Bill alluded to the work we did in Ontario, establishing family health networks and teams. Initially a very slow process, but now has become not the norm of care, but certainly the number of family doctors in these renewed models is by far the majority. There have been some interesting evaluations done of this work by our unit at Queen's University, along with Rick Glazier at ISIS. And I shouldn't give a nod to Marshall Godwin, who's here, who was our first research director at Queen's and really set the stage for the work that Queen's has been able to do. So Mike, Rick, and others showed some regional variation in access to family doctors in Ontario. And this is the part that I think is the challenge from my point of view. We established in Ontario networks of family doctors, asked them to work together in groups, paid them differently, moved to formal rostering, introduced pay for performance and capitation, promoted electronic medical records, and we've had, as I said, great uptake, but still an uneven distribution of these teams throughout our province. And Mike tells me it would cost about $64 per person to extend teams of this quality throughout our province, an investment well worth making. And of course, important work on the lived experience of Indigenous peoples and type 2 diabetes in Canada. So again, that important and urgent challenge to spread what's known about new models of care to all Canadians, including Indigenous populations. From the US, I love this license plate. I didn't know you could get a license plate saying everyone deserves a family physician. So just turning briefly to the US, and I'm not from the US, but I have friends and get to attend some meetings. These are just my observations. Every time I read Atul Gawande, I cheer, and his article on incrementalism made me chuckle, because it seems to me that as he tries to figure out a better way in the US, he comes very close to family medicine, but he can't quite name it. Yeah, okay, you agree. So I don't know, some of you know him, please talk to him. He's you know, he gets it about relationships. He gets it about, he calls it incrementalism, which we would call continuity and comprehensiveness. And so I hope at some point he'll be able to name it for what it is, what the US, I feel, needs. I'm saddened to see how indicator overload, the electronic medical record, have led to high levels of burnout amongst colleagues in the US, and we certainly see some of that in Canada. The US, they call it WAC, work after clinic, and it's part of my life as well. We've got to have electronic medical records that provide the tools for quality, for sure, but that don't overburden us as clinicians. We're interested in Canada in learning more about new models of care, and of course some of the best models of care that perform really well for patients are also seen in the US. I'm interested in accountable care organizations and primary care governance and improving accountability. I mentioned our Queen's Policy Group has been studying the US, studying the UK, thinking about all this, and we have some blogs on our website that you might want to look at, particularly about ACOs, which I think might be a way forward in Canada and certainly seem to have some promise in the US. But maybe there's some papers here I don't know about which evaluate them differently. Okay, a little bit about researchers. I don't think can read this, but these are some of the silly ICD-10 codes sucked into a jet engine subsequent encounter. Swimming pool of prison as place of occurrence of external cause. These are actual ICD-10 codes. So this is just a plug. You know, in Wonka we have ICPC, the International Classification in Primary Care. Probably a better way to think about the work we do than some of these. Burn due to water skis on fire, subsequent encounter. Struck by macaw, initial encounter. All right. At the Kingston Summit, and I should acknowledge Chris Van Weel is also here this morning, past president of Wonka. These were some of the, when I say the Kingston Summit, I'm referring now to those the wastelands of Canada that Horton visited. But the outcomes of that summit were important. And just to remind us, it's a few years ago now, 2004 this was published, but these challenges remain for us. The need to assess new knowledge in relation to the study population from which it was derived. So can we generalize this to other patient populations? Still a question for those of us in family medicine. And important to critically appraise the potential risks and benefits of any innovation for patients in each primary care setting. So the critique of the family health teams in Ontario, I welcome that. Let's take a look at any of our innovations to see if they're actually achieving what we want. And the development of practice-based research networks, which I know have been have grown tremendously in the last 15 or 20 years, but still an important laboratory for the work that we do. Rich Roberts, another president of RONCA, says if we want to see evidence-based practice, we need practice-based evidence. Seems like a tautology, but I believe it to be true. So my thoughts about, you all know your star field, and I was going to rehearse all of star field, and then I decided, of course, I wouldn't. But what's happened since then, of course, we need urgently still to replicate our findings, to examine them in different contexts. But some of the additional learnings, for me, Kurt Stange's paper on the primary care paradox, so important. The paradox, the idea that for any particular disease, the technical quality of care may well be better if delivered by specialists, and yet paradoxically, outcomes for patients and populations are better if delivered by generalists in relationship-based care. Always holding that paradox in tension. So easy to do research, the ain't it awful sort of research where you can pick any disease and show that family doctors don't do as good a job as exologists, and yet keeping in mind what Starfield taught us and what we need to keep figuring out and we need to keep figuring out how this works. How does that primary care paradox operate at the level of the patient? Since Starfield, we've learned that we've got some great research on teams, and this comes from an article which I've cited at the bottom by Starfield's collaborator, that it matters what your team is like. Good teams are good, poorly functioning teams not so good. So we like to say team, 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 but it does matter what kind of team you have. And probably a team that's not too big is better than one that is too big. Access, very important, and emerging more and more that at least for non-urgent emergency room visits, improving primary care access makes a difference. Of course, we'd all like to see the reduction in the urgent visits as well as a result of good primary care. I think it's out there. Maybe someone can find the evidence. And increasingly, we have evidence of things that don't work. Lots of people have tried things in obesity, nurse-led geriatric outreach. There's all kinds of pilots that have failed for one reason or another, and important to look at those as well. And just to realize that the work we do involves large numbers of people over long periods of time. It's based in messy and complicated relationships, and so it's very difficult research to do. The most intellectually challenging research you can find, I would say, and so I salute you for undertaking all that. Starfield's last message for us were these three questions. They'll be familiar to you, I expect, but just to remind you, she asked, how do we develop primary care research to address the challenges of care for people with comorbidities? Because we are aware of that primary care paradox. And we are aware that somehow we integrate care for individuals who have many conditions, but how do we show the importance of that? How do we use information from primary care to improve population outcomes? So that interface that Margaret Chan spoke about between public health and primary care, how can we actually show that? And then patient-centeredness, or what I like to talk about now as person-centeredness. How do we truly adopt that, measure that, show that? What indicators can we have for that particular important aspect, of really central aspect of our work? That relationship between individuals. This patient, this is me making a house call a number of years ago. I show the patient with the permission of her family. She's blind, but in the picture, but we still can communicate. And I was there when she died. Well, actually, I wasn't there when she took her last breath, but I hopped on my bicycle and cycled over and pronounced her dead while her family was there. And again, I'm not sure why I'm showing you this, except to say, to recall the importance of that relationship, the relationship I continue to have with her family, which was built on the original relationship with Grandma. In Canada, we have for years used these old 4 principles, and I still think they're so important and so central. The doctor-patient relationship as being central to what we do, but the keystone or capstone is our work as a skilled generalist clinician. We're not just about relationships without tools and skills. We're based in communities and we serve a defined population. all of that together, fertile ground for research for a lifetime agenda. These last couple of slides are from Michael Kidd, another past president of WONCA, and he tells us, and I believe, that family medicine is the only way we'll effectively contain rising healthcare costs, especially through support for preventive care, health promotion, chronic disease management, and again, comorbidities. Family medicine is the only way we'll effectively manage the healthcare needs of the elderly in our nations and tackle the epidemics of both communicable and non-communicable diseases. It's the only way we'll tackle the workforce shortages, that map I showed you of doctor-patient ratios around the world, especially through supporting teamwork. It's the only way to effectively address mental health problems, and I haven't talked about that so far, but of course, all of you know in our offices that's that psychosocial context is such an important part of just about every encounter. And finally, ensuring that high-quality healthcare is available to all persons in each country, including those who are disadvantaged. The power of family medicine to transform the world. So with that, I bring you greetings and perspectives from Canada, and I wish you well for the rest of your conference. Thank you.
Thank you so much, Dr. Wilson, for an inspirational kickoff to our meeting. I'd like to invite folks to come forward. There are microphones for questions. I think she's happy to take some questions for the next 10, 15 minutes or so. So please come up for questions.
Or comments, or you can go to coffee. You can go to coffee soon. And I've invited my friends to please throw me softball questions. Not even that, Mark. Everybody wants to have coffee. Yes.
Hi, my name is Chavata Benkin and I'm from Israel. I have a remark and a question. The remark is when you show the universal coverage, Israel is also one of the countries that we have universal coverage, and even the access to family medicine is like 100%. The average number of visits is, average number is 8 visits a year. And we have really, and it was not shown on your slide.
Thank you. I will update.
Please. And we have universal coverage, like from the time we are a country, or even before, from 1911, when the first Jews came to Israel, we started having universal coverage. You pay when you are healthy, so that at the time that you will be sick, you'll get free services. And since we are a country, we have universal coverage for everything: primary care, secondary care, tertiary care. Secondly, you show 10 10 major cause of death, and I didn't see cancer. Is it 48 was other, so where is cancer? It's known as the second cause of death.
Certainly very important, and I won't recall the slide, but I'll review it. Thank you. Of course, cancer is an important cause of morbidity and mortality. Interestingly, cancer deaths are on the rise in Canada and the US, whereas death rates from cardiovascular disease are decreasing, although they remain amongst the most important causes of mortality. I know the eagle eyes have been looking at my slides, so I'm sure Fred Burge is going to tell me something else. Fred.
No eagle eyes on this slide. Fred Burge from Halifax. So first I want to thank Ruth for my research career.
Are you going to tell the story?
I am.
All right.
I was a medical student with Ruth in coastal Newfoundland, and we wrote a great first paper on the purple bag syndrome, which was about purple catheter bags. And she led me to stop and think about why things are the way they are when we see them. And so I just want to say thanks to Ruth for her career.
Well, the other secret on this is this was a letter to the editor in Canadian Family Physician, and both Fred and I at various points in our careers have reviewed each other's CVs, and think both of us dropped that first publication.
You can now get it in PDF, so it's really cool. It's great. Ruth, I do have a question. Thank you for a great presentation. As always, you challenge our thinking and keep us moving ahead, which is fantastic. You have a lot of experience in having shifted the landscape in Ontario, and some of us in other provinces are only beginning that march around shifting that landscape substantially in what I think is actually maybe a tougher time than it was 15, 20 years ago, particularly in the lives of primary healthcare providers and the complexity of care and some of the challenges in doing that and a lot of burnout going on. You got lessons about engagement. I'm really interested in how we engage the providers in the primary healthcare system to be bold, to be innovative, and to step across that threshold into new ways of working.
I think the main lesson in Ontario that led to successful development of a model and implementation was the ability to work across jurisdictions and to talk to people that we don't necessarily always talk to. So the Ontario Chairs of Family Medicine, which I was a part of at the time, included Brian Hanan, Walt Rosser, myself, and others. We wrote an academic paper about 9 points for primary care reform and published it and thought we'd done our work. And then we thought, well, if we actually want to make this happen, we're going to have to talk to some other people. So we started talking to the Ontario Medical Association, found a small number, but one or two who were also interested in reform. Started talking to government, who we hadn't really thought were very supportive of family medicine, and they had not been up until that point, but they too were interested. And then we spent quite a lot of time just meeting informally and working through what would it mean to have a rostered population? What would it mean to work in teams? What ought the model to be? And then we went on to participate in fee negotiations, which I never thought I would do, that I would be a negotiator on fee settlements. So being willing to work with partners who you think might not have the same interests as you do, and in fact probably don't have the same interests as you do, can lead to this getting to yes, or this win-win program that we were able to do in Ontario. I agree the landscape is more difficult perhaps now than it was. We had the burning platform back then of 5 million Canadians without access to a family doctor, and that really led to political will to make the change. And political will, of course, is so important. Engaging healthcare professionals and family doctors can be tricky, but I think the main thing always is to appeal to our altruistic vocation for medicine to serve the patient, and that is the way that we can rally around reforms. If they're better for patients and if they're also good for us as providers, that's the way I think that engagement happens. Maybe Michelle, and then one more, and then Mark. Maybe we'll have coffee with that. Michelle.
So just like Fred, I'd like to say thank you. You made my life and my practice better. I was one of the people who joined early on. You convinced me cavitation was the way to go. Team-based medicine was the way to go. And it's benefited my patients and me. So thank you.
Wow. Thank you. Thank you, Michelle.
I do have a question.
Yes.
I'm anxious. And the reason why I'm anxious is because we have switched to electronic medical records. We have vast amounts of EMR data in primary care in Canada, but well over 80% of doctors are using them, and the private sector wants these data. And there's currently quite a tussle between the private sector companies that own the products in which our data sits, and those who are not so interested in having the private sector have control, etc. And I'm not sure how this is going to go. I think it is, as you said, a political problem. How do we think constructively about addressing the issue of control of primary care data for the majority of Canadians? What is the appropriate balance between the private and public sector with respect to control of data?
Wow, a question that I don't know the answer to, and I don't suspect many of us do. I'm not an expert in this field, but my thoughts would be to go back to basic principles. So first principle is, whose data is it? It's data about the person, the patient. I absolutely believe patients need access to their own records, and I know some of you are developing or work with those kind of electronic portals that allow that. We do, at a practice level, absolutely need access to rolled up data. And so I see Dave Barber from our department sitting in the front row here. We've just recently in our own department initiated an opioid prescribing quality assurance exercise. So I know how many of my patients receive more than 50 morphine equivalents per day, and I'm working hard to reduce that number. So that practice level quality improvement data, which is anonymized, very important. Public access to data, the public sector are the funders of our healthcare system, and I believe they need rolled up data for accountability purposes. Private sector, you'd have to make a pretty good argument to convince me. I don't see where they come in my first principles from an ethical point of view. So I would need myself to hear a convincing argument if I were going to go beyond that. Maybe one final question. And sorry, I can't see who you are.
Hello. Yeah, my name is Karen James. I'm a person with lived experience of addiction, and I've worked 20 years in the addiction field. I'm just a bit concerned. I've tried very hard to encourage the University of Ottawa, where I live, I'm from Ottawa, to do some education of their new doctors on addiction, because there seems to be a lack of education, and that's the problem with that is people have been prescribed, for instance, benzodiazepines when they are alcoholic and without follow-up, without sort of medical supervision, leading to death. And just the attitude towards people with addiction, the lack of knowledge around addiction with primary care physicians, and would like to be part of making a change with that, but can't seem to get anyone to sort of respond to the issue or show any interest. And I think at the addiction field, we see a lot of lack of health care and primary health care for people with addiction.
Well, thank you very much, Karen. Clearly, a very, very important issue. The opioid epidemic has really brought it home to all of us in the U.S. and Canada. And, you know, speaking as a clinician myself, my own education about addictions was very, well, non-existent. What I have learned has been a great deal from my own patients who've taught me about the things that have worked in their lives, that have helped them on the road to recovery. And the contribution of persons such as yourself with lived experience to our educational programs and to our research programs is key, and we're just learning how to do it. We're new to it. I know there are colleagues from Ottawa, many of them in the room, who will want to connect with you afterwards, but I thank you for being our last questioner and bringing that patient voice to us. Thank you.
So thank you again, Ruth. That was a very inspirational talk, and thank you, members of the audience, for some great questions. Please go enjoy the poster session, hopefully a little extra time for coffee this morning, and enjoy the rest of the meeting. Bienvenue à Montréal.